Hello and good evening, everyone. Welcome to our 70th Blue Hills Virtual Seminar. Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia in collaboration with Ethiopian Society of Hematology and Oncology. Blue Hills Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Yeno Taddele, a general physician and first aid trainer from Blue Hills Ethiopia. Today, it's a pleasure having Dr. Munir Awol here with us to have a seminar on principles of radiotherapy. Dr. Munir is a consultant clinical oncologist at Addis Ababa University. He completed his undergraduate study in medicine and postgraduate study in clinical oncology at Addis Ababa University College of Health Science. He did a fellowship in advanced radiotherapy at the University of Oslo, Radium Hospital, and University of Witwatersrand, Johannesburg at South Africa. He's the head of the Department of Oncology at the Columbus Hospital and works as a vice president for the Ethiopian Society of Hematology and Oncology. He's also the head of oncology clinic. So to give you a background on today's session, the session will last for about 90 minutes, and after that, we will have a few minutes for question and answer. So participants, please direct your questions in the Q&A section and not the chat box. So participants can take the short quiz at the end, and those who score 60% and above can get a 1.5 CEU CPD certificates for only 100. And information regarding the certification process will be communicated after the end of the session by tomorrow via your email. So participants, please pay attentively to doctor's presentation. Dr. Munir, the stage is all yours. Can present.
Okay, thank you very much for the generous introduction. And good evening, everyone. So I will take you through the basic principles of radiotherapy. I mean, how professionals who are not familiar with the workflow and the jargon of radiotherapy needs to understand radiation as used in the treatment of cancer. It's our daily routine in our department, but even for myself, when I first joined residency, I mean, everything was new. So I have this understanding that professionals in other disciplines might not really be close or have an idea about radiotherapy. So I'll share with you what principles really guide radiotherapy in the treatment of cancer, some historical aspects and the like. So the presentation will have a background, and I'll speak on how really radiation works. That is how radiation kills tumor cells. And I'll also talk on the types of radiation treatments we have in general, in the treatment planning, in the delivery system, and few case examples. So if I begin my speak by stating some facts from the World Health Organization, which usually adopts cancer epidemiology from another entity called the GloboCan, which is a global cancer registry network. By now we have understood that cancer is really a big concern in terms of public health. We know worldwide it has become a leading cause of deaths, accounting nearly 10 million deaths in 2020, which is like nearly 1 in 6 deaths. So, we are living in underdeveloped country, and what's really concerning is in the coming 2-3 decades, the GloboCan estimates that 2/3 of new cancers will develop in these emerging economies or in the developing countries. So we are not yet done with transmittable diseases, infectious diseases, and other NCDs to begin with, like cardiac, pulmonary, and many of the other things. But like 2/3 of the new cancer burdens are expected to occur in the developing nations. So you can imagine that the burden will be facing in the near future in terms of cancer. So if you ask me if cancer can be cured, my answer is yes, because like nearly 2/3 of cancers are expected to be curable, but this has to do with early detection and effective treatment. The majority of pediatric cancers are expected to be cured, and the majority of solid cancers, if caught early and treated effectively, can expect a significant cure rates. But the truth is we have a very high cancer fatality rates at this point. This is due to late presentation. This is due to lack of access to essential medicine and essential care in general. So we have like 3 main arms of treatment for cancer. So as you know, surgery has been a main curative treatment and palliative treatment in numerous cancer cases. Radiotherapy has always been used in the treatment of cancer since its discovery. I will speak about some historical facts related to radiotherapy just in the next few slides, and of course, systemic therapy. So these 3 main treatment arms are the corner stones for managing any cancer. So it be surgery, radiotherapy, and systemic therapy. Of course, systemic therapy, it used to mean, as a synonym like chemotherapy, but nowadays we have lots of options of therapies, like hormonal therapies, targeted therapies, biological therapies, immunotherapies, cancer vaccine therapies, and the like. But we always classify them under the umbrella of a systemic therapy. Because the topic of discussion here is principles of radiotherapy, so we have like a unit to measure radiation, right? So the radiation we use in cancer treatment is ionizing radiation. We call it ionizing radiation because, radiotherapy is one spectrum of these electromagnetic waves. But the form here is ionizing radiation, which is to refer a radiation or an energy which has a capacity to ionize when it comes to interaction to an electron or a given medium. So this specifically is to mean it has to have an ability to eject an outer shell electron when it comes into contact to a medium. So any energy, electromagnetic wave with the capacity of ejecting an outer shell electron, we call it ionizing. It's capable of ionizing a medium. We call them ionizing radiation. Okay, and the unit we measured this radiation dose is called a gray, and it is written with this unit. So when you read the textbooks, you may see like radiation doses written with this unit. So it refers to 1 joule of energy, joule of energy deposited per kg of a tissue. So it is 1 joule of energy deposited per kg of a tissue, and we call that gray. We also have terms like fractions. Okay, whenever we prescribe radiotherapy, say you have a cervical cancer patient, and the cervical cancer treatment basically has 2 phases of treatment. On phase 1, for example, doctor or an oncologist may prescribe like 50 or 45 to 50 gray of radiation. So this does not mean that we give like the whole 50 gray of radiation on the same day, okay, or the whole 45 gray of radiation on the same day. So radiation is not usually given like that. So if you have X amount of radiation required to control a cancer, we usually divide that X amount of radiotherapy in small amounts, and we spread that like in numerous consecutive days. For example, if you have 70 grays of radiation, which is the usual dose prescription for tumor control in the head and neck region, we usually give this 70 gray of radiotherapy in 35 sessions. So 35 sessions, each session administering just a small amount equivalent to 2 grays of radiation. Okay, so instead of like giving 70 gray just in a single day, so this is going to take like 35 days or 7 weeks of treatment. So the reason we give radiation in smaller doses is basically to make it more tolerable. Okay, and there are other principles why we need to give radiotherapy in small fractions and not like big fractions at once, which is also possible. I will again say few words about this subsequently. So the treatment, because we have divided it and we are going to administer it in consecutive days, we usually do it on Monday to Friday. This is just conventional way of administering radiotherapy for many reasons. There's no scientific reason usually, but Monday to Friday are working days and the weekends are like many of the staffs will be off duty. You need to give time for the patient to recover from the radiotherapy. You could do it like on any day of the week, but it's better you give like enough amount of radiotherapy Monday to Friday and give rest for the patient and for the normal tissues over the weekends and start from Monday again. So this is how conventional radiotherapy works. But we understand some tumors may not really need any interruption due to their fast proliferation and everything. So they say, okay, rest may not be required for some of the tumors. But in conventional terms, treatments are delivered Monday to Friday and no treatment over the weekends. And treatment will resume on the next Monday and the same will be done until the required amount of radiation is administered. We do have different kinds of electromagnetic waves capable of ionizing a medium. I'm referring to ionizing radiations. You can have like photons, which are widely used in radiotherapy. The hospitals in Ethiopia with radiotherapy machine, the 3 of the hospitals do have linear accelerators, and basically these linear accelerators, they have a dual energy. So like 98-99% of the time we are using photons. These are X-rays from these machines, but they are also capable of emitting electrons, producing electrons from the same machine. They are dual. They mean they have a capacity to produce photons, X-rays, which is what we commonly use to treat cancer in our setting and everywhere in the world. But they are also capable of producing electrons. So there are some characteristic differences between these photons and electrons. The photons, they have a higher energy and they go deep into the tissues. The electrons, usually they don't go deep into the tissues and usually they are meant to treat superficial targets like skin cancers and the like. Okay, we do also have other kinds of ionizing radiations like protons and particle therapies. These are very expensive machines and energies to treat cancers with, but they got like some specific use and indications, especially in pediatric cancers and other rare situations. So we have something called internal radiation, but this usually refers to radioisotopes as used in nuclear medicine. So the focus of this radiotherapy principal discussion is on photons and electrons and other similar energies. So if you go back to the history, so this William Röntgen was the first guy who discovered X-rays in 1895, a German physicist. So he discovered X-rays, and because at the time there was like no other way of treating cancers, the scientific community was so excited, and the discovery of X-ray was almost followed by the use of X-rays for the treatment of cancer. No time was wasted during that period of discovery. So soon after the discovery, people have used X-rays for the treatment of skin cancers. Unfortunately, this discovery of X-ray was followed by the discovery of radioactivity. Radium was discovered by Marie Curie. So all these discoveries have really led to an attempt to try to help cancer patients. So except for surgery, there was no much to be done that time, right? Chemotherapy discovery came a bit late after the World War. So the only treatment they could give other than surgery at that time was radiation. So X-rays were like extensively used for the treatment. This radioactive materials also were used for the treatment of various neoplasms. An example here is a treatment of a brain tumor with radium. So they put it on the on the skull. So interestingly, because people were very much excited about the discovery of this radioactivity in X-rays, so they used these X-rays for like a variety of diseases. It wasn't, in fact, only cancers that was treated with radiation back then. A lot of infectious diseases, fungal diseases, including TB, pneumonia. All these diseases were treated with radiotherapy. One, because the discovery of antibiotics came late, right? So in that century, so even these infectious diseases used to be treated with radiotherapy. In fact, the consequence of, because tinea capitis, due to the socio-economic status of that period, they used to be common, and they used to be treated with these radiations. And unfortunately, like when these kids who had treatment with radiotherapy for their tinea capitis, when they were followed for some time, some of them developed CNS neoplasms, radiation-induced CNS neoplasms, and in fact, that opened the radiation safety issues, radiobiology issues, and much of understanding of concerns of radiotherapy really followed that when it was used with low doses, as in medical treatment. The rest of radiation safety and everything came, in fact, after the atomic bomb explosions in Japan. So we have machines like this until the early 1950s, where the first cobalt machines were introduced. Okay, these cobalt machines primarily use gamma rays, as I said, as an ionizing radiation, and these linear accelerators, they use a fast moving electrons to produce photons. So you can have like different forms of ionizing radiation and different forms of machine which are capable of producing these energies. But if you wonder like how radiotherapy causes damage, or how radiotherapy is capable of killing tumor cells, then this is a very uneasy way to explain it and to grasp the basic thing about the radiotherapy activity. So for the radiotherapy to work, in the first place, there has to be a target for the radiation. Okay, radiotherapy works if there is only the right target for it. So what does it mean? So it only means that people, in fact, have proven this concept by doing some basic experiments. So these basic experiments are like, people have in laboratories, they exposed cells without their nucleus for a radiation, and later they reintroduced their nucleus, which inside of it is obviously the DNA. And when they observe, if a cell is exposed with a radiation in the absence of its nucleus, it's unlikely to die and it's business as usual. But when they irradiate the cells, after reintroducing the nucleus and the DNA, then you can see the effects of radiotherapy. Cells can be successfully killed, and growth can be inhibited. So through this and other multiple similar experiments, people have come up to the conclusion that the target for radiotherapy must then be the DNA. So for any ionizing radiation to work, the target remains this DNA molecule. So as you know, the DNA is a double-stranded molecule, and this ionizing radiation carrying some energy because it's a photon can do at least two things to the DNA. One, this photon can directly, go and interact with the strand of the DNA and it can break it. This is a photon ionizing, it can eject electrons, right? So they can directly interact with the strand of the DNA molecule and they can break it. We call this the direct action of radiotherapy. We call it a direct action. So it is directly on the DNA strand. But you can see like the size of the DNA is around 2 nanometers. It's a very small molecule. So the chance that this interaction happens is low, right? So if you consider it as a probabilistic occurrence or a chance occurrence, so this energy, this photon interacting with a very small molecule is unlikely. But what is really likely and what is what happens most frequently is an indirect action. So this indirect action is the same photon. When it hits the cell, it first hits the water molecules because the water is what's abundant in the cells, right? So 70% of the cell is water. So in the cytoplasm, what is very abundant is water molecules. So when a radiotherapy interacts with any tissue or any cell, so what is very likely is that this energy gets deposited in the water molecules. Because these energies have the capacity to break the water molecules will break down and form hydroxyl free radicals. So these free radicals, as you know by nature, are very reactive species, intermediate species. They don't stay, they need to bind whichever is near to them and creates damage to the DNA. So this indirect action, in a sense, is not the effect of the photon directly on the strand of the DNA. Rather, this photon hits the water molecules. The water molecules break down and form free radicals, and it is the free radicals, in fact, that cause and breaks the strand of the DNA. So due to this, we call this an indirect action of radiotherapy. And for the reason I stated, due to the abundance of this molecule and water molecules in the cell, they are going to happen more frequently. And this is the predominant occurrence in radiotherapy cell kill. So if you see the biological effects of radiation in humans in general, not every tissue line in human beings have the same radiosensitivity. So some cell lines, they have a higher sensitivity than the others. Basically, this difference comes from how active these cells divide in the first place. So cells which have a very high turnover number will be affected by the radiotherapy most likely, and cells which are terminally differentiated or which are less active are unlikely to be affected by radiotherapy. So this works for the normal cells and the normal tissue lines. So this may mean that patients develop all the side effects based on this principle. For example, radiotherapy, when it hits the scalp area, you see the hair loss. Alopecia can be induced by radiotherapy, like it is induced by chemotherapy. You can also have like sore throats, mucositis, because these GI layers, they have a very fast turnover, then they're easily affected by radiotherapy. In the pelvic, you can see diarrhea. In pelvic radiotherapy, you can have cystitis when the bladder mucosa gets damaged. But the others, cardiac, nerve tissues, and the like, they fairly resist radiotherapy. So tissue lines which are derived from tumors, if they have a very high proliferative rates, then they are likely to be radiosensitive. For example, lymphomas, germ cell tumors are very radiosensitive because they have a high proliferative index. They divide very fast, so they are likely to be affected by radiotherapy as well. So radiotherapy effects, you can classify it into acute and chronic. Okay, the acutes are usually what comes in the first weeks or in the first 90 days, and the chronic or the late side effects of radiotherapy are those that come very late in the process, usually after like 90 days of radiotherapy. So the acutes are the ones I already said, and the chronic ones are usually considered at late effects, and they are usually the most difficult ones to deal. So there are measures to decrease the consequence of, the probability of happening of this late effects. Otherwise, if they really come, sometimes it may be difficult to do anything about this. There are second neoplasms, cardiac issues, renal issues, GI issues in terms of long-term toxicities, pneumonitis, and the like. The list is so many. So, but we do have like the technology, we do have a good radiobiological understanding as to mitigating ways. Ways to minimize the chance of these severe late effects, especially if we are talking, for example, in pediatrics age group. This could mean a lot for growing kids. So there are ways to minimize these things from making like serious damage in the long term. So not everyone has a similar sensitivity for radiotherapy. For example, if you add in the treatment of radiotherapy additional chemotherapy, we call it concurrent or concomitant chemoradiotherapy, then there will be more sensitivity, more damage to the tumor, but it means also more damage to the patient as well in terms of side effects. Some autoimmune disorders, because we have said the target is DNA, and some of the autoimmune disorders may have impaired DNA repair capabilities, and this could really enhance the DNA damage. It may mean a good thing in terms of tumor eradication, but patients are really at a very high risk of radiation-induced problems. So these are the issues. The reason we give, I'm really afraid. I came home hoping that there is an electricity. My laptop is dying. So let me see how far I can discuss, and I will see how we can continue. Okay. So we have like different fractionation schemes. As I said, we don't give the full dose of radiotherapy at once. You have to give it like in few amounts spread over consecutive days, usually taking few weeks. The typical radiotherapy prescription usually takes 5 to 6 weeks of treatment. So the reason is it reduces normal tissue toxicity, because by making it over a period of time, it gives normal tissues time to repair. Okay, and again, because not every tumor cell is in the same phase of a cell cycle during the treatment. Some of the phase of cell cycles are more radiosensitive, like the mitotic phase and the late G2 phase. So if you allow some time before 2 radiation sessions, then the tumor cells may cascade from one of their phase of the cell cycle. If they were, for example, in the G1 phase, they may go to the S phase. If they were in the S phase, they go to the G2. If they were in G2, they go to the N phase. So there is a chance that you can catch the cells in different cell phases, and you can increase sensitivity. Also, it gives time for some of the hypoxic cells to gain more oxygen when the dead tumor cells fade and they have a better tumor microcirculation, and this oxygenation helps increase the tumor radiosensitivity. But it's not always a good thing making like treatments over a period of days or weeks. If you allow like more time to complete a treatment, then the tumor cells, the surviving few tumor cells, may get the capacity to grow again. We call this a repopulation. Okay, so especially when patients get sick and they are unable to continue their treatment, or when there is a Martian breakdown, and when the overall treatment time of the radiotherapy is increased, unfortunately, some of the surviving few tumor cells can grow again, and this can result in toxicities. So this is really a problem. But there are ways again to do something about these issues, okay? So whenever you do the treatments in radiotherapy, you can have different ways of doing the treatments. We have basically two major machines to deliver radiotherapy. You have an external beam radiotherapy, where the source of radiation is at a distance. The external beam radiotherapy, its other name is a teletherapy, tele to mean at a distance. Okay, so these machines, they give their radiation without the need to be very close to the patient. Usually they deliver the treatment like at 70 or 80 centimeter, or sometimes at 100 centimeter from the patient. So it is like a CT scan machine. The patient will lie on the couch, and the source of radiotherapy is in the gantry, in the head of the machine, and there is a clear big distance. But brachytherapy, as the name suggests, is a treatment where the source of the radiation is very close to the tumor, usually inside the patient. A good example is an intracavitary brachytherapy, which we commonly use in gynecologic malignancies, in cervical cancers, where you put dummy tubes inside the uterus, and under computer guidance, radiotherapy is delivered like inside the uterus. Okay, so this is called a brachytherapy. Some unsealed sources like iodine 131 can also be inserted into the interstitium of tissue, like in prostate radiotherapy. So these are a permanent way of doing radiation as well. So these are the ways external beam radiotherapy works. This is a patient lying on the couch, and this is the gantry, the head of the machine, and the source of the radiotherapy, okay, is produced here, and it comes through this. So there is no contact between the patient and the machine. So the radiotherapy will be given this distance. So this is how you, for example, do a breast radiotherapy. We take a CT scan, you contour, you delineate your targets, you delineate some organ at risks, and a treatment beam will come from each side and deliver a required amount of radiotherapy without much affecting the normal structures. We do have some special kind of external beam radiotherapy. We call it a stereotactic radiosurgery. This is with the hope of replacing the need to do some surgery in difficult, inaccessible areas or in patients who may not be candidates for surgery. So basically, radiosurgery is a delivery of a very high dose of radiotherapy, usually in single fraction. Instead of giving it in multiple fractions, you can also give it in few fractions, not like in 5-6 weeks, but in 2-3 days, 4 days, you can give it. But you deliver very high dose of radiation to a smaller area, okay, in a very precise manner. You can see like fixing the patient's head here so that there's no movement at all, so that the radiotherapy can really target this area without affecting more sensitive normal structures like the brainstem and the like, in case of stereotactic radiosurgery for the brain. But this is a kind of an external beam radiotherapy. You do use multiple radiotherapy fields to concentrate on, to pinpoint on a very small area. The brachytherapy, as I said, it is putting a source of radiation, okay, inside the interstitium. Okay, here it is guided by an endorectal ultrasound, but we do have other forms of brachytherapy for soft tissue sarcomas as well, for the breast and the like. This is the machine. So the radiotherapy source is kept here. Okay, it is sealed here so that the personnel are protected. Okay, when it is needed under computer guidance, you can connect dummy tubes to these machines and patient can be treated. So here is how we treat gynecologic malignancies with these applicators. So this will be in the uterus, and this will be just on the cervix, and they deliver a required amount of radiotherapy to where it is needed. So the advantage of this brachytherapy to the external beam radiotherapy is the radiation is much of kept where it is needed. So there is no radiotherapy much going to the bladder, back to the rectum, or the other normal structures, which is very difficult to have in external beam radiotherapy. So that this is one big advantage of brachytherapy. So there are like some workflows in radiotherapy. You have consultations. Once it is decided, patient will be simulated using a CT scan, usually sometimes with an MRI. So from the CT scan, we get the idea of where the tumor is, how big it is, what is around it, and the like. So we do contouring. Contouring is basically delineating the tumor and its adjacent normal structures, and some planning is done. Okay, dose of radiotherapy is required, and that plan is reviewed. Then some quality assurance activities are done, and patient will be ready for treatment. So this is how we cascade the patient workflow in radiotherapy. So these are the workflows in radiotherapy process. And before patients receive their actual treatment, these are the things we usually need to do. Some quality assurance activities, because the idea of simulation is simulating the actual radiotherapy treatment, which may not really be the case. So whether we are in a good position to deliver the treatment or not needs to be checked on a daily basis. Please, next. So the first process in after getting the simulating image, what we normally do is contouring. Contouring is, we have a software tool which will help us like delineate the different regions of interest. We have two basic regions of interest. One is an organ at risk and the other is the target. So radiotherapy, the principle basically is you try to deliver a treatment to your target, but at the same time you need to be very cautious so that the normal structures are not harmed, right? So to do that, you need to identify the normal structures. So whichever is near the target needs to be contoured. It could be optic nerves, for example, in head and neck radiotherapy. It could be the kidneys in abdominal radiotherapy, the liver, the bowel, and the like. But for the target volumes, we will identify what is visible on the necktie, on a physical examination, or on imaging. It could be from a PET scan or an MRI or a CTV. We call that a GTV. This is the gross tumor volume. We'll delineate that. And following surgical seriousness, we have a good understanding that by treating just the gross tumor volume, you may not be successful, right? For example, the surgeon will not just remove the tumor which is visible, right? Usually they do wide excisions so that they can also remove microscopic areas. So we have a similar principle in radiotherapy. You don't just treat the tumor which is visible on the CT scan. You treat a normal appearing tissue around this visible tumor on a CT or MRI, and we call that normal looking tissue which may harbor microscopic disease as a CTV, a clinical target volume. We also delineate some lymph nodes at risk, elective nodal volumes, and we do give some additional safety margins. Okay, patients may move during treatment. There is respiration. There is a lot of uncertainty in radiotherapy, so we have safety margin so that we don't miss the tumor. Please, next. So you can see that a grossly enlarged lymph node is contoured here, right? And on cyan color, you can see the non-involved lymph node regions are also contoured. So this is the contouring process, which may not be visible for me, but so in such cross-sectional image, when you do the contouring, the normal organs at risk of interest will be the spinal cord and the like. So you need also to do contouring of the spinal cord so that when you attempt to give a dose of radiotherapy to these targets, so that you make sure that the spinal cord is not injured in the process. Please, next. So this is a final 3D version of what the final contours looks like. You have the targets, the eyes, the lymph node regions, the spinal cord, and everything contoured. Please, next. So this is a similar contouring process in the pelvis, showing elective nodal contouring relevant for pelvic radiotherapy. Please, next. So this is how you can probably identify your target based on the imaging capabilities, right? So if you have PET scans and the like, you have a better identification of your targets so that it is not confusing from a normal structure or other confusing pathologies. Please, next. So please, next. So once we finish the contouring, then we have medical physicists by profession who will be doing the planning. So this is like arranging fields where the beams should come and how much of the beam should come anteriorly, how much of it should come from medial, how much of it should come posteriorly, so that our objectives can be fulfilled. Our objective is to give as much dose as possible to the tumor and as low dose as possible to the normal structures, right? So in the lower panel, for example, you can see a breast being treated, but these fields should not touch and go to the heart. So this planning activity is done by the dosimetrist or a medical physics personnel, but at the end, the oncologist needs to approve if this meets the objective of the treatment. Please, next. Okay, so this is the physics keyway, is the one I already said earlier, to make sure, because there is a human error, there is a machine error in it. So before you give treatment for patients, this quality assurance activities needs to be performed, verification of dosimetric calculations, other optimization of treatment plans, a measurement of dose which is to be given for the patients needs to be checked in tissue or human tissue equivalent phantoms. We have these phantoms for the same purpose in hospital, so you need to check. So this is how the physicists check the dose distribution in similar activities using a phantom. So this is a phantom, and it has an exact similar tissue equivalent structure. Then you can understand the dose distribution and the like. So the treatment initiation and filming, this is to verify that patients need to have the same position during simulation and during treatment. So the only way to make sure that during treatment the patients have the same position as they were during simulation is to take an image during treatment. So the machines are capable of taking images. The linear accelerators, the radiotherapy machines we use for the treatment, they have a different arm to take images. So these images are used to verify that the patients are aligned and positioned exactly the same during their first simulation during the CT. So we do this on a daily or weekly basis depending on the intention of the treatment and the site, the mobility and everything. So we do have some radiotherapy emergency scenarios. You can have cord compression. You have to treat this like in no later than 72 hours of symptom onset. We do give whole brain radiotherapy for case of symptomatic brain metastasis. radiotherapy is very much effective for bleeding control, and we often use it in pelvic malignancies like cervical cancer with active vaginal bleeding. We do use it for patients who have upper airway obstruction or superior vena cava syndrome, or it's also very commonly used to control especially bone pain in patients who present with bone metastasis. So these are some of the clinical scenarios we use it as an emergency or as a priority. Otherwise, for example, when you take the example of cervical cancer, nearly 70% of cervical cancer patients require radiotherapy at some point during their treatment. And in general, like 50 to 60% of patients, cancer patients, will require radiotherapy at some point during their natural history of their disease. And if you, come to developing countries due to disproportionate prevalence of these pelvic malignancies, breast and the like, the need for radiotherapy, and again, their late presentation where surgery may not be feasible, makes even radiotherapy indications very, very high. So, just an additional information of interest will be radiotherapy safety. So, the two most important things for radiotherapy safety will be time and distance. So, if you're away from a radiotherapy source, likely you are safe, right? So, constructions are designed in a way to block any exposure of radiotherapy to the personnel and to the public. So we call it this shielding. But even if you have adequate shielding, you need to be at a distance so that your exposure will be really minimized. We call it an inverse square law. So if you go a given distance, then your chance of exposure or the dose you receive is inversely proportional to its square of the distance you're away from the source. And also how long you have stayed in the area of exposure also matters. So if you are not like a personnel who works in the radiotherapy department, don't spend much in hazardous areas, but we do have limits for radiotherapy personnel, limits to pregnant people, there is limits to the public, and this is a matter of regulatory bodies. Okay, this is the end of my presentation. I'm really sorry for the inconvenience that's created. I would really like to answer your questions if I'm able to catch it from the text box, or if it's possible to read it.
Okay, thank you very much, Doctor. And thank you to all participants as well. And those of you who have questions, you can write down your questions in the chat box and the doctor can address them. We have one question by David in the chat box, and it says, are those medical physicists available in Ethiopia, and also the different types of radiations are available here? Are they available here?
Yeah, medical physicists are available in Ethiopia. So there are few in number, but for the available machines, I see they are fairly adequate. So we do have a very well trained medical physicists at Black Lion Hospital, at Harar Haramaya Fana Hospital, and at Jimma University Hospital. So these are the hospitals currently with a radiotherapy facility, and all the three have well-trained medical physicists. So there is no training for radiotherapy medical physics in the country. All were trained abroad, but currently they are here, and they actively engage in the clinical work. So is one-time exposure for radiotherapy at risk? Yes. So any exposure makes a person at risk. So the risk can be different. Okay. For example, the atomic bomb exposure, it's just a single exposure, right? But the amount of radiotherapy is so huge, so it was devastating, right? So it didn't stop at just that time point, right? So the problem, you see it even now in terms of hereditary conditions and the like. Yes, so radiotherapy, depending on your age of exposure, your status at the time of the exposure, age for women, for example, during pregnancy or whatever. So you have definitely a risk even from a single exposure. But if you get exposed like multiple times, then the risk increases. Okay. So that's why, for example, unnecessary multiple exposures of radiotherapy from for medical reasons, for example, CT scan for X-rays may not be really a good thing, and one needs to balance the need for that imaging versus the long-term risk from this radiotherapy. Cancer is increasing alarmingly in Ethiopia. Yes, definitely. The different types of radiotherapy machines are available in the country. So currently, all the 3 centers have one functional linear accelerator. Okay. So BlackLine, in addition, it has 2 cobalt units. Usually they are not functional. Currently they are not functional, but 2 cobalt machines, 1 linear accelerator, and 1 currently brachytherapy is available at BlackLine Hospital. So brachytherapy and external beam radiotherapy is available at BlackLine and Jimma.
So
renal,
yeah, that question is renal C.
Yeah, renal C is radiosensitive. So radiosensitivity is a relative. So radiosensitivity is a relative term. Okay. So if you compare renal cell C with other tissue lines like lymphoma or germ cell tumors or squamous cell carcinoma, it may not be radiosensitive. Okay, but the indications for radiotherapy in renal cell C is very, very limited. So primarily it's a surgical disease. You remove it with surgery. If it is not amenable for surgery, I mean, if it is metastatic, then systemic therapies are given. There is no need to use radiotherapy. In fact, the normal kidney cells are very, very sensitive for radiotherapy, and they get easily damaged. And radiation-induced nephropathy is what we really fear when we irradiate other intra-abdominal targets.
Is radiotherapy possible to be used in pregnant women, basically?
So as much as possible, you have to avoid radiotherapy in women who are pregnant. Okay, but if there is if it is a must to use radiotherapy, you can use, for example, in the head and neck region. Okay, you can make shielding and patients can receive radiotherapy. Okay. And the other is, it depends on the pregnancy gestational age. For example, if it is early, it's better if terminated. Okay, if it is late, then the radiotherapy consequences for the fetus are relatively low, so it may not be really a problem. So the most sensitive period of pregnancy for radiotherapy is the pre-implantation phase, followed by the phase of organogenesis. So past that, you can probably fairly use radiotherapy if it is a must, but avoid it as much as possible. Yeah, but it is doable.
So Zanara asked that, as you have said, majority of cancer patients require radiation therapy, but we only have 3 radiation therapy centers. So how do you see the accessibility issue and its impact on cancer patients' mortality?
Okay, thank you. Very good question. So the World Health Organization in the International Atomic Energy Agency, the IAEA, has come up as to what is optimal radiotherapy machine access for every country, because it is difficult to give the same definition for the developed and the developing countries. For low-income countries, the minimum radiotherapy machine required is 1 for 1 million people. So if you have 1 million people, you are expected to have 1 machine. Okay. So Ethiopia, as you know, is a big country, more than 110 million. So definitely Ethiopia needs like 100 plus machines. Even in Addis Ababa, you need to have like, I don't know how much is the population of the Addis Ababa, but you need to have 7 to 10 machines in Addis only. That's how it should be. So you can imagine what 3 machines can serve. So the waiting time, for example, at BlackLine Hospital is close to 2 years. So you need to wait like 2 years to receive a treatment.
We can add 1 or 2 questions. Is radiotherapy applicable in children?
Radiotherapy is applicable in children. accessible or applicable?
Applicable, it says. Is it
Yeah,
applicable?
yeah. So radiotherapy has a very wide indication. So in pediatric solid cancers, there are very well-studied indications for radiotherapy. Okay. Even in hematologic malignancies, radiotherapy has a place in terms of conditioning regimen, in terms of controlling sameness disease. So yes, radiotherapy is applicable also in the pediatric age groups. But you see, given the toxic nature of radiotherapy, it is not something easy. It's not something that you generously do, especially when they are very young, growing. The long-term consequence of radiotherapy in kids can be very alarming, right? So for a specific age group, especially for less than 2, less than 3, you may differ or you may delay the need for radiotherapy. If it's a must, you have to use it, but if there is a place for a systemic therapy, so patients can be put on a systemic therapy so that you can delay the need for radiotherapy and the like. But yes, it is feasible and it is doable, and there are wide applications of radiotherapy in the pediatric age groups as well.
Okay, one last question. I'm not sure if you have addressed it previously, but when you do stereotactic radiotherapy, for example, in medicine, the brain, how do you succeed in salvaging the normal tissue above and below the lesion?
So the stereotactic radiotherapy as a technique is different from conventional radiotherapy delivery. So it requires basically two more specific qualities to be checked. One is the need for precision. Okay. You see, earlier I said when we do contouring, we draw the GTV, we draw CTV, we add some margins for uncertainty. But in stereotactic radiotherapy, precision is very important. So basically, you have to be precise by a millimeter to deliver it. So there's no a wider margin. Usually, these treatment volumes are small. Okay, an ideal tumor volume in the brain for a stereotactic radiosurgery usually is less than 4 centimeters. Okay, so these are small volumes, and there has to be precision. So to bring this precision, one, the patients need to be fixed to the table, with near perfection. There's no way that the patient moves even by a millimeter during the delivery. You have to be that precise. So this will lead to the accuracy of your target, right? Then you are safe from the adjacent normal structures. So they used to pin the patient. Okay, they put pins, screws on the skull so that the patient wouldn't move at all. Okay, but we do have other technologies now to do a less invasive way of keeping that patient strictly immobile during delivery. And the other thing is you have to use imaging capabilities. Okay, during delivery you need to have imaging to make sure that the patient is in the same position. Okay, and if possible you need to visualize the target as well. So these imaging capabilities, immobilization capabilities, and a smaller volume of diseases makes stereotactic radiosurgeries feasible, so that you can safely avoid harming the normal structures around. And the quality of the radiation, which is a bit technical, also allows the delivery of such high dose of radiotherapy without a spill, without this dose of radiation going to the normal structures. You can really just target the lesion.
Okay. Thank you. On behalf of Blue Health Ethiopia and all our participants, thank you very much, Dr. Munir, to present on today's session on such a short notice, to take from your busy time as well. It was an interesting and well informative session as well. We also would love to thank Ethiopian Society of Hematology and Oncology for the collaboration of this webinar as well as the previous ones. and also for the future. Thank you very much, Doctor. And if you have anything that you want to address at last, let me give you the stage one more time.
Thank you very much for allowing me to replace the previous speaker. It was an unfortunate event, but we really didn't want to leave this vacant, so I wanted to just to try my best to present, and I hope you have gained some from my talk. So I'm really happy, and the participants really I liked the questions, and hopefully we'll see you with another talk from Ethiopian Society of Hematology and Oncology, and we'll have our annual conference in February 24 and 25, and you all are invited to join the conference in person, and you'll have very exciting sessions during the conference as well. Thank you very much again.
Thank you very much, Dr. Munir, and good night.